I'll outline my approach today about what I do when a patient returns after a handful of days of performing a specific repeated movement daily throughout the day and reports he is overall 50% or more better. That's the subjective report before we get to anything more objective. 50% improvement in 2 or 3 or 4 days is something you often see with the phenomenon of a diagnosis of a joint derangement. That, of course, is very in contrast to a lot of orthopedic disorders. I know this because prior to learning Robin McKenzie's work, I didn't understand the concept of a joint derangement that was rapidly reversible. That wasn't on my radar as a possible diagnosis. Now that it is, I find 70 to 80% of orthopedic disorders are tweaked joints, if you will, that will rapidly respond when you have the right motion under the right load, the right force, and the right dosage and frequency. But other orthopedic diagnoses, for example, tendinopathies, which I'll find in a limited number of patients, they're not going to return 50% better in 4 days. If they do, I'm pretty much ruling out that it was a tendinopathy, and I'm looking for what I may have missed. But other orthopedic disorders that I don't tend to agree with anymore as a pathophysiology, like IT band syndrome, that person's not coming back 50% better in 3 days. Inflammatory conditions might, if you reduce inflammation, but an inflammatory disorder to me is not an orthopedic disorder. We would name the orthopedic disorder underlying it that causes the inflammation, but if you're treating inflammation, you can see rapid changes. Anyway, say this person comes back 50% better. What I'm going to do in this appointment is basically the same thing I do for an evaluation. I don't really love the word follow-up, to be precise. I like the word evaluation. Every appointment is an evaluation of the person's life up until that point. So on visit 2, it's just an evaluation of everything up until visit 2, and what we changed between visit 1 and visit 2 is included in that. But we're looking to see in part 1 of any evaluation the verbal history. So in my follow-up, I'm doing a verbal history. I'm getting a lot of information. There's going to be information that is helpful in understanding whether or not the retraction or shoulder extension or whatever it was that the patient was doing over the last 2 or 3 or 4 days is going to be indicated more, or if it's possibly reached a plateau and something else might be even more effective. We know that this specific repeated movement the patient's been doing is not making him worse, but the job of today's appointment is to figure out if more time with the same movement is indicated, or if doing something slightly different or radically different would be even more beneficial. So some verbal questioning is part and parcel of coming to that decision. For example, if the more the patient does that repeated movement over time, if it wasn't painful at the beginning and now it's painful, that's making me think we don't want to keep going into that direction. We've reached the number of reps that we can get that are effective out of that movement, and we probably need to look for something else. Conversely, if the person said initially when I did knee flexion, etc., it hurt and now it doesn't hurt anymore, that may be more of an indication that we need to keep doing this movement. So the questions I'm asking the patient help me start that critical decision making about what to do for the new exercise at home or the new program at home. There are other questions besides just does it hurt when you do it, of course, but I'm not going to go into all of the questions. Patients who come to see me have actually usually been to another physical therapist, and one contrast with the way I treat versus other therapists or other doctors is that a lot of my appointments are talking. It's really important for me to get the information that I need to understand the pathology completely and make the best decisions. It's not like patients come to me and they go over here and do their bands, go over there and get the massage, go over there and get the ice. I have a very small office, of course, but it's a lot of talking and really understanding what's best for the patient. But part 2 will be taking the baselines. If the baselines are just a handful from the initial evaluation, like 3 or 4 or 5 things are wrong in terms of range of motion, strength, nerve tension, functional baselines, something else possibly like balance or reflex or something more kind of rare, If there's only a handful of those, I might test all of them. But if there were 8 or 9 or 10 things that we found wrong in the musculoskeletal system that I think are likely related to the disorder, I might just pick the ones that I think are the most key and retest those baselines. So the patient's subjective report may be 50% better. I'm looking to see how much better the mechanical findings are. Is range of motion actually better? Is strength better? Is nerve tension better? Is a step up better? Is a push up better, etc.? So that second part of the evaluation, the mini evaluation, is also giving me a lot of information. Part 3 now, what I know is I'm going to ask the patient to do the exercise from the prior home program. And so the way I approach it, if someone's considerably better, is I will do more of those and maybe 20 or 30, and then retest mechanical baselines. And if the person is symptomatic when he walks in, retest or ask, are the symptoms changed? But I'll probably do 20, 30, 40 and see if there's still a positive effect. Because if you're doing a large dosage at one time versus just 10, and we know that was helpful, I would still expect to see an in-office change if we're doing that, if the movement is still effective. So if we do 20, let's just say we do 40. If it's an easy motion to do, like 40 side glides on the wall or 40 knee extensions, it really doesn't take more than a few minutes. I might break it up, of course, into 10s or 20s if I feel like the patient's a little bit more vulnerable and I have to recheck baselines to make sure we're not making anything worse. But at this stage of the game, if we've already done 200 or 400 of these repeated movements, I feel comfortable in most cases just saying, all right, let's do 40 knee extensions or let's do 40 side glides and then retest. So say we've done that chunk of repeated movements, we'll retest the baselines. And if I see enough change to make me want to continue with that home program, that's what we'll do. We'll give it more time with the same repeated exercise at home, performed roughly 10 repetitions throughout the day. If I don't see a change, however, and of course if I see a worsening of the patient's presentation, then we're going to evaluate and look for other ones. So you can see how it's very similar to a standalone evaluation, except for here, I'm already starting with a repeated movement that we've been doing and seeing if it's still beneficial. So if it's not beneficial, depending on how the mechanics change, and I've gone into this in another video, but how the mechanics do or don't change really tells me about where to go next. It's not just trial and error, like, oh, if side glide doesn't work, let's try rotation. If rotation doesn't work, let's try flexion. It's not how it goes. If mechanics change in a certain way, I may, or they don't change at all, I may add force to that specific repeated movement. I may add force via kind of overpressure with my hands or with the patient's own body weight. I may add force by making the motion sustained. So that's where, of course, repeated movement testing becomes quite cause and effect and algorithmic. Clinicians need to know how to interpret the findings and what it indicates going forward. So I'll look at another repeated movement and still look for the one that I think is going to be the most effective to send the patient home with. Oftentimes, if there's such a beneficial response, like 50%, it will be indicated to add a little bit more force if we haven't added force, or at least moving up the force chain, if you will. So if the patient was providing overpressure, maybe I can have him or her get someone at home to provide a little bit more pressure externally, or another way, or maybe sustained. Sometimes I have patients get mobilized by their significant other in the house or their children. We can add a little bit more force in a lot of these cases, but not necessarily. Sometimes we can also add more reps. But it's sometimes there's no effect by adding more force, or I don't want to look at more force based on what I see. And so we'll look at a completely different repeated movement. So that's kind of the paradigm of how I approach those specific patients. It's not necessarily more of the same. It's really just evaluate the patient now that you know that 4 days of doing XYZ has improved the patient's subjective report 50%. See if we need to change something, or if we don't, and then the patient will go away for another few days and come back again with a new set of data. I've done this more time, I've done the same exercise for more time, or I've done a new exercise for this period of time, and we'll assess the effects. All appointments that I conduct really fall into those 3 stages: specific verbal history, take the baselines, and testing. typically repeated movement testing, because I find that most patients have orthopedic disorders that are joint derangements, but not always. If you're looking for ligamentous healing, your testing would be testing the integrity of the ligament. But those 3 stages are really kind of form the backbone of my appointments, whether or not it's the evaluation or follow-ups, because all appointments are really kind of like evaluations.